Right, so I think it is now time. It's now 2 o'clock in the UK, and thank you all of you for joining this. As I think it's about the 5th LTC COVID webinar. Today we will be talking about barriers and challenges and also opportunities in using data in order to prepare and respond to the COVID pandemic. We can, and the presentations will be a reflection of both opportunities that we potentially have to use data better, challenges there have been in terms of using data, and also we'll have a bit of a look at some of what the initial data may be telling us. We're going to have presentations from the UK, also some specific data analysis from London, from Brazil, and then from Canada. And I'm really delighted to introduce the first speaker. This is Dr. Jenny Burton. And Jenny, you have the floor. You have about 10 minutes. Thank you.
Okay, so thanks very much, Adelina. I'm really grateful for the opportunity to participate in the webinar this afternoon. So just to give you a wee overview of what I'm proposing to talk about, I'll just do a little bit to set the scene, talk a little bit about Scotland's care homes and our data infrastructure, and then talk about the wider UK challenges posed by COVID-19 and the opportunities that we have moving forwards. But before I do, I should start with my disclaimer, which is that I have a passion for care homes and enabling evidence-based care for older people and people living with dementia, and I see better use of data as an integral part of that. My other confession is that prior to COVID-19, I have a data linkage project, which is the historic legacy of my PhD, for which it took over 3 years to secure all the relevant permissions and access to the data set. So although this is only the second time it's been done in Scotland, I'm not naive to the complications that there are about using linked data, but very much believe and support their use. Of interest, back in 2018, we identified what has proved to be one of the biggest challenges in the UK, which is that we don't have a good, reliable way of identifying who lives in a care home. And that sounds like quite a fundamental challenge, and it really has proved quite a barrier, and one that I hope that we can redress moving forwards. As a second aside, I'm using the term care homes, and it doesn't sit easily with everybody. To explain, that's because in Scotland we don't have residential or nursing care homes. That division doesn't exist. Our regulator instead describes care homes as those with or without on-site registered nursing staff. However, unfortunately, that variable isn't systematically recorded in the publicly available national data, and thus we're left describing care homes as if they are a synonymous group, which I appreciate is suboptimal, but for the ease of terminology, I'm going to stick with care homes. It's interesting to note that care home terminology is a big global research issue, and during my PhD, we actually did a study looking at how care homes and long-term care settings are described internationally. And it's one for which I'm very welcome that the country reports that are coming through from LTC COVID include a definition of the services provided and the population served, as it's so key for us all to be able to compare results. So to set the scene then, this is a map of all of Scotland's care homes and shows you their vast scale and the different populations that they serve. At the start of February this year, there were 1,084 adult care homes, and the UK care home statistic all care home researchers like the best. There are 3 times more beds in Scotland's care homes than there are in the entirety of the acute NHS sector, and that's very important both in terms of interpreting results but also understanding the needs of this population and how poorly served they have been through data. 75% of our care homes are for older people, but they actually make up 90% of the beds. The majority are privately owned, but this figure is much smaller than the comparable figure for England, and they're regulated by the Care Inspectorate, who produce aggregate summary data on their services. In terms of Scotland's social care data infrastructure, it is generally considered more favourable than the other countries of the UK, and some of the examples of the data collection systems that we have in place are listed there. In particular, a strength is our annual care home census, which is in fact the feature and the focus of my linkage research. However, the main challenge is that there are national flags in our healthcare data sets, but we know that it is traditionally very difficult to both identify residents, but also therefore to understand who's newly admitted to a care home from hospital and to understand the flow in the system. In terms of the COVID challenges in particular, one of the major ones is that much of the reporting has lacked that denominator of the population and the understanding of their breadth and scale. Of interest also, and this is similarly an issue in England and Wales, some of the really key data are collected by the regulators for care, whose primary role is in care assurance and regulation, and that's what we would want them to focus on as opposed to being a provider of statistics. Mandatory reporting of both mortality and outbreaks of infectious disease have been a long-standing feature of their role, but they've never before been asked to publish these data, and certainly not in the timeliness that has been demanded by the general population and politicians. As I've said, we have particular problems looking at data of residents who are hospitalised, both in terms of identifying the population and understanding the flow and the role that care homes play, particularly in supporting people as a step-down service or intermediate care from hospital, which are just massive data gaps exposed by all of this because we don't really know what normal looks like. Data linkage is of course one way of addressing all of this, but it takes time and requires shared identifying variables across the data sets which have historically not been present. These are what are required to be able to produce anonymised, individual level adjusted analyses, the creme de la creme, really what we're all looking for to try to explore aspects like mortality with a degree of meaning. In terms of the outputs we have seen, so we've had weekly death reporting, which includes place of death, but importantly, in-hospital deaths are missing from this data. The Scottish Government data has moved to using that from the Care Inspectorate and summarising outbreaks and testing, and more recently looking at weekly data based on care home size, location and sector, but they don't provide us with the real richness of information that we want. Because the questions that are of interest to us obviously are much broader than simply counting the number of outbreaks, counting the number of deaths. Although these things give us some quantification, they lack the meaning. And as I've said, the biggest thing that is a challenge is we don't have good normative data about what normally happens over this period of time. We understand the phenomenon has been extreme, but any kind of understanding of what normal flow particularly is really missing at scale. So the opportunities moving forward, well, I think it's safe to say the data gap that we've been describing and others like us is now very much on the agenda and recognised as something that needs to be addressed. During the pandemic across the UK, we've seen a rapid increase in access to digital technologies, which is very welcome for the sector. There's also, rightly or wrongly, a political imperative to address perceived mistakes and an opportunity there to try and address the differences between the quality of our health data and our social care data, bringing social care data up to the high quality that we have from health data. Of course, really importantly, however, is that we've seen massive amounts of engagement from within the care home sector who really want their voice to be heard. And I see that there's an opportunity for academic teams, frontline practitioners to work together to make sure that care homes and their residents aren't invisible in our national data sets moving forward. However, there are some things to take into account before we go out root and branch and make changes. And that is the fact that our care homes collect huge amounts of data every day, and that the care landscape in the UK is very complex with lots of different care providers. International empirical large-scale data sets, which have been used in other countries, haven't been widely adopted here, and attempts to implement them haven't proved to be feasible in our quite different social care-driven care home sector. Also important is, despite the digitalisation, many care homes still use paper-based records for their everyday work. In terms of the challenges that need to be addressed then, so if we're going to have more responsive data systems, they need inevitably investment, but also the infrastructure to support them. Clearly, it's vital for us to protect the privacy and safeguard the data that are being collected from very vulnerable residents, many of whom lack capacity. And it's interesting that the Understanding Patient Data initiative, which exists for health data in terms of canvassing public attitudes, there isn't an equivalent for social care, and that may well be an avenue to explore. But finally, repurposing data that were collected for a different reason in the social care sector mean that they have differences of meaning. And so we don't just need analytical capacity, we need that to be paired with expertise in the subject. On a relatively linked and relevant initiative is this work, the DACHA study, which I'll introduce just briefly. Importantly, one of the aspects of work that we're proposing to do as part of this is to develop a UK care home trial repository, which again is about understanding, making better value of the data that we already have and improving the feasibility of future research. And I've included in the links a link to a video that my colleague Lisa Irvin has done explaining this part of the study in more detail. So in terms of my reflections then, COVID-19 has exposed what was known but is now appreciated on a wider scale, that the invisibility of our care home population across the UK. However, it's important that we recognise the root problem here is not a lack of data, but a lack of timely linkage and analytical capacity to bring things together. Improving use of that data offers huge potential to improve frontline care, service planning, and ultimately evidence-based policy making through better informed research. However, it's really important that anything which is done takes account and understanding of the UK care home context. It's important that we recognise that this isn't a matter of being a simple reuse of data that we all understand. It needs time, infrastructure, capacity, but most importantly, joint working. Care homes, and by that we mean relatives, residents and staff, the care home providers and representatives must be partnered in any academic or policy endeavours to make sure that we understand what the data really mean, and most importantly, that use of their data are used to benefit this population. I've included some references that will be hopefully helpful if people wish to follow up on the additional interest and reading, and we'll just close, and I'm happy to take any questions at the end.
Thank you very much, Jenny. Just to remind everybody that we make the video and the slides available usually 1 or 2 days after the webinar, so you'll be able to access those references then. So thank you very much, Jenny. We now have Jose Luis Fernandez, my colleague from CPEC on the School of Economics.
Thank you very much.
Yes.
Okay, so what I would like to present is a work that we've been doing myself, but also many colleagues from CPEC, and here are their names, and I absolutely want to acknowledge them because this has been a big team effort. So I'll read the names: Javiera Cartagena Farias, Francesco D'Amico, Amritpal Regil, Sam Rickman, Kevin Wren, Wembo Song, and Juliet Mali. And we've been working together with basically the Greater London local authorities. So the ADAS, London ADAS stands for the Association of Directors of Adult Social Services, in order to support ADAS and London ADAS in their analysis of the impact of the COVID pandemic on the social care sector in Greater London. And as part of this collaboration, what we've been doing is collecting a great deal of data. We've been surveying providers, and I'm going to talk specifically about the survey covering care homes for older people in London, but we've been getting information from those providers now since the end of March in order to understand key impacts, but also some of the factors that might explain why different parts of the care sector have been affected differently. And so what I want is just to provide an overview of how we've used that data. But also, I want to tell you that the analyses are ongoing, and therefore, this is still very much work in progress. Very briefly for our international colleagues, so the Greater London area covers about 9 million inhabitants. In terms of the care sector, in terms of older people care homes, we're talking about approximately 650 with 28,000 beds. At the moment, about 21,000 residents. Comparatively speaking, across England, but also the UK, it is characterized by a lower number of beds per capita. That's partly to do with the obviously the demographic profile of London. And in terms of we do have this distinction between residential and nursing homes. Nursing homes look after people with, generally speaking, people with greater needs, and they've got slightly different staff profile because they employ nurses on a 24-hour basis, 24-hour per day basis. And the other thing I would say is obviously London, high population density, but also pockets of deprivation. So there's quite a lot of variability within London, which is something that from an analytical point of view, at least, is quite interesting and useful. So this has been rehearsed many, many times, so I'm not going to go into this in any sort of detail, but obviously social care was always going to be at risks from COVID-19. And so what we've tried to understand in terms of the data that has been collected are things like the extent of prevalence of people with symptoms, COVID-19 symptoms across different care homes, the mortality levels, the impact on quality, or at least whether different providers of different quality might have been affected differently, impact on workforce, and finally, we're looking also at the impact on financial sustainability. We're also doing other things, but those are key objectives of the analysis that we're doing. This is not data from the collaboration, but it's just to illustrate a point that I wanted to make, which is that the data that we are using is data that is being collected, as the previous speaker was saying, very quickly, and therefore is subject to some limitations. I think it's still very good data, but nevertheless, for example, if you want to measure mortality related to COVID, we know that no matter what sort of method you use, you're going to get only part of the picture. So this slide shows the estimates of deaths involving COVID-19 on the basis of death certificates from the ONS, which should be a highly reliable source. But depending on whether you're looking at those deaths which are specifically noted as related to COVID-19, or whether you look at just all excess mortality in care homes compared with previous years, and on the 1st of May, you get an answer of either 10,000 deaths or over 20,000 deaths. And of course, it's all about how you interpret the data, and there are reasons for those explanations. My point is that the data in this type of situation, it's always going to be subject to interpretation and caveats. So this is data that has been collected through the London survey, which has approached all the care homes on a daily basis. And as you can see, London was, this shows two things. One is the numbers of residents that were suspected, and this is very important, not on the basis of testing, although there's been more and more testing in the last few weeks. But these were basically largely the figures over the first few weeks were largely based on the perception of the care home manager of the numbers of residents with symptoms, COVID-19 symptoms. And you can see how the peak was the first couple of weeks in April, and since it's been going down. We've also been measuring mortality in those care homes, and probably data from CQC and the ONS is better across the country, but nevertheless, we've had this data, which I think is still reliable and useful. We did change the indicators that we used on the 21st of April, so you see a break in the series, and now we've been collecting data on mortality related to COVID, or at least to people with symptoms, mortality which is COVID related, but that happens in hospitals, and then overall mortality in the care homes. And the point is that you can see that about half of the mortality that we've seen was linked to COVID. There's a lot of mortality which is not necessarily related to COVID in care homes. But more importantly, when you break that down by types of homes, you see that the patterns are quite different. So this is breaking down our data on prevalence and numbers of deaths and mortality between nursing homes and residential care homes, and you can see how the bulk of the mortality has happened in nursing homes, but also the prevalence of COVID-19 cases has been much greater in care homes. This is even when you take into account the fact that there are many more nursing beds than residential care beds in London, and I'll show you some figures for that. This is just a curve looking at daily mortality, and you can see how that's been going down, and now it's really, really close to zero. What I'm going to show you is that, of course, because we know where each of those care homes is located, we've been able to map how, from a location point of view, geographically, how the cases developed. And so what I'm going to do is, as I press the button, is to have a little bit of, it's like a mini movie, which shows how the cases spread across London in terms of care homes. Each of those dots is a care home, but also it shows how now it's all becoming white, and there's many fewer care homes with somebody showing showing symptoms. So I don't have time to go into the details of these, but you can see how, as I say, there's a lot of white. There's also pockets of red in the north of London. But if another way of showing that trend is to look at the proportions of the homes that have got residents with COVID-19 symptoms. And you can see how at the peak, we were talking about 43% of the homes across London with at least one of the residents with suspected COVID-19. And that's now gone down to 20%, which is obviously much better. But also you can see how the prevalence was very different across different types of providers. So big providers, the green line, were much more likely to have at least one of their residents with COVID-19, and still do, than small providers. And this is, I think, in part the fact that if you've got more residents and your plane dies more often, if you see what I mean, you've got the probabilities is always going to go up as a result of at least one of your residents having COVID-19, but it's also the fact that bigger homes might be more difficult to protect. And in London, at least, the small homes have been extremely good at keeping COVID out. What we've done is match that data to other data about the characteristics of those homes, but also the local characteristics, the local area. And although these are still very early results in terms of the modeling that we've been doing, we are finding some results which are, I think, very interesting, and very interesting in terms of thinking about a risk and how to target support for care homes. So as you've seen already, and I think this has been highlighted in other studies as well, the size of the care home is very, very important. It's one of the major factors in explaining variations in the prevalence and mortality. So we've looked at prevalent numbers of, or the proportions, whether a home is hot or clean, and the numbers of people in the home with COVID-19, and also mortality in the homes. And the results are fairly consistent across. So the size of the care home is very, very important. The type of the care home, even after you control for the size of the home, is still important, although less important. So nursing homes doing worse even once you control for the size. It shouldn't say home care quality, but care home quality. So the rating shows signs of being associated with COVID-19 outcomes. Some local deprivation indices are correlated, even standardizing for other factors, with the COVID-19 outcomes at the care home level, and staff unavailability is something that is very, very important. Now, one of the challenges in terms of staff unavailability, which makes sense, if you've got there's likely to be a correlation, or you would expect to be a correlation. The problem is that there's some potential for endogeneity there, in the sense that if you've got fewer staff, you might run the risk of not protecting the home and the residents adequately. But equally, if there is an outbreak in a home, that might affect the staff, and so that there's a two-way relationship there, and which we're working on disentangling. But also, it's important to disentangle the workforce effects between something about the quality of care, which might be perhaps proxied by the numbers of staff to residents, but also the numbers of staff themselves, because each staff is a risk, as it were, and also the type of staff. Are you using agency staff or not? Is your staff moving from different homes? And we're working on that. Staffing, as I said, it was something that was very, very important, and we've been collecting data in terms of the numbers of staff that were unavailable. The one striking curve is the green one, which shows that very quickly after the beginning of the outbreak, we saw up to 4,000 staff not able to work, and that's been getting much better. That's the key. Well, very briefly, I will also say that although there were a lot of people that were missing, in terms of the ratio of staff to residents, that wasn't quite as bad. And the reason was that care homes, at least in London, have been able to draw in agency staff. But that in itself is a challenge. Now, finally, we've been looking at financial sustainability, because although you've seen that the numbers of cases have gone down, you've seen how the proportions of I think there is a... Oh, sorry, there are questions. I thought it was Adelina telling me that I didn't have any more time. How much more time have I got?
José Luis, you have about, I think you have about 1-2 minutes, if we're very
2 minutes
good
is
to
all
you.
I need. That's
Good.
perfect.
And we will go through the questions afterwards. So please keep adding them to the chat box and we'll make sure they all get addressed.
No problem. So all I wanted to say is that although there's been reductions in numbers of cases, in the proportions of the homes affected, and in the workforce, improvements in the availability, the actual occupancy levels haven't picked up. They decreased. They decreased in particular for big homes. You can see how they were around 90% pre-COVID. They're now around 75%, and that's an average for those. So there'll be some homes that have been very significantly affected. And so what we've been doing is looking at the extent to which, and this is on the basis of lots of assumptions, which I cannot go through, but basically, we're simplify the world, just think about comparing to what the situation was before COVID-19, and just assuming, forgetting about all the help that care homes might be getting at the moment, just look at the impact that the loss of income through voids and changes in staffing might have had on those care homes. This shows the distribution on a daily basis of the impact on their revenue prior to COVID-19. So those homes, for example, here would have been losing half of their revenue pre-COVID-19. Now, one thing I will say is that clearly, in terms of the overall impact, it's those big homes that have been most affected. They're the ones that have had, because they're big homes, they've had lots of voids, and therefore the accumulated impact has been bigger for them. But in terms of the risk as measured by the proportional revenue that you might lose as a result of an outbreak, that is concentrated on the smaller providers. And this is shown here. This shows you the average daily financial impact as a proportion of initial revenue. You can see how that volatility, as it were, is much bigger for the smaller providers than the big providers. I'm going to leave it there. Adelina, we can talk about questions later on, but I'll leave it there. Thank you.
That's great, thank you. I think you will have quite a few questions by the looks of it. Thank you very much, José Luis. So our next presenter is Patrick. Patrick, is it Patrick Alexander? Not very sure I can pronounce the surname properly, but thank you very much for joining us. Would you like to share your screen?
Thank you, Adelina, for your kind invitation. Congratulations for all the magnificent work leading this initiative. In the next minutes, we hope to share with you some of the preliminary results of our research we are conducting here in Brazil and in Latin America, and to talk about barriers and challenges and opportunities we are facing in Brazil in the last few months, particularly concerning the access and use of care home data to inform the response to COVID-19. Brazil is a huge and continental country with more than 210 million people living in a theoretically democratic society with a robust rate of economic and social inequality. particularly when comparing the different regions of the country. But even in the wealthiest cities, we can find differences, particularly in the poorest sectors where the population live. From February 2020 until Saturday, Brazilian government had officially registered almost 5,000 deaths due to COVID-19. Yesterday, this number was overtaken. In the last weeks, we have recorded daily average of approximately 1,000 deaths. In the same period, we had 3 different ministers of health. We have been highlighted in international news. And more recently, the government had thought it would be advantage to have some tricks with official statistics. So in fact, the officially released data, we may find, for example, in the Johns Hopkins sites, may have some difference or perhaps some bias in relation to the data released by other sources, including consortia of journalists and consortia of researchers. Usually the data informed by the government is something like 1,000 or 1,300 deaths difference from the numbers informed by this consortia. What we know is that when suspected cases are identified or perceived by local health authorities like physicians or nurses, they should notify all suspected cases, not just hospitalized ones. So people with flu syndrome or severe acute flu syndrome fall into the definition case of a suspected case. They must enter in this site to notificate the case. This registration must be performed within 44 hours after this suspicion. And after the severity stratification, severe cases are referred to referral centers or to specialized care, while mild cases and patients without comorbidities are monitored in their own homes with a quarantine for at least 14 days. Agents from both public and private care must perform this notification. There are public health surveillance systems like ISUS, where this kind of notification is performed, and where just physicians or nurses that have access to internet, they can enter this site and enter data so they can register this suspected case. This is a graphic from this official site notifying all the new cases per day from the official site of the government. But even before the blackout of the data promoted by the government in the last 3 to 4 weeks, we were facing some problems with data related to care homes, because all reported data that were identified on this ISUS surveillance data, they use home address as the key identificator. So when we have care home workers that are contaminated, that are a suspected case, they will be identified in this system using their own home addresses. So we don't have how to relate they as a suspected case to the care homes. So it's difficult for us using this ISUS surveillance system to relate care home workers to a care home, because all the system relate them to the address of the person, not to the address of the care homes. When the case is related to a resident, to a people who is living in a care home, we have a bigger problem because we have a lot of care homes in Brazil that are unregistered or are informal, and it's difficult to provide specifically a quick response when we have outbreaks, because it's difficult to find these cases using systems like Jose Luis shows us, because it's difficult to identify these cases quickly, because most cases, most care homes, sorry, are not registered, and they are not particularly recognized by the system as officially working. Early last May, a consortium of Brazilian and Latin American researchers started a survey with care home managers to identify and describe how they prepared and how they are facing the COVID-19 pandemic. So we will briefly present the preliminary results of this investigation, which today counts with the results of 255 different care homes in Brazil and 23 in other Latin American countries. I apologize for presenting some results and graphs extracted directly from Google Forms without proper statistical treatment and without proper translation into English. We have data of about 8,200 residents who is living in care homes that responded to our survey. Among respondents, care homes were most often for-profit or non-profit philanthropic units that receive government or non-government subsidies. Due to the pandemic, the influenza vaccination through the National Public Health System was anticipated this year. So more than 95% of the units responded that their residents had been vaccinated as well as their workers. Regarding social distance measures, only 12% answered that they still only partially adopted measures of minimal physical distance between residents for general care homes activities. And during meals, the effectiveness of this measure is reduced, and just over 60% reported being able to stagger meals or serve them individually and in the residents' rooms. Most respondents reported that residents and workers are having access to personal protective equipment, including masks and alcohol gel, for example. But the availability of these supplies, however, is already a matter of great concern. They are already out of stock, or the available stock is only sufficient for up to 7 days in more than a third of the sample. In addition to the lack of personal protective equipment, half of the respondents already find it difficult to buy or to maintain their stocks. Access to laboratory tests for serological or PCR diagnosis for SARS-CoV-2 and influenza are also uneven. Just over 40% have access to both, probably the private care homes, while 26% have neither tests. Just over half of the respondents reported having the necessary infrastructures in their care home to properly carry out the isolation of suspected confirmed cases of COVID-19, including space for workers to safely place and remove PPE. And during the survey, we had no provision for investigating measures of occurrence of COVID-19 cases. But the answer to this question, what has been your main source of information for facing the pandemic, caught our attention because there are a lot of responses as other sources, and most of these responses were public prosecutor. So we started to looking for the to get in touch with public prosecutor from all states in Brazil, asking them if they were in contact or supporting care homes during the COVID-19 pandemic. We were able to establish partnerships with the public prosecutors of at least 6 Brazilian states whose public agents had been carrying out online survey activities by online video conference or monitor by telephone calls with a large number of care homes. In some of these states, to guarantee the human rights of the residents, the public prosecutors managed to include even clandestine or unregistered facilities in these surveys. So we would like to present some of the data of 2 of these states. This is the data from the public prosecutor of the state of Santa Catarina. They have 241 care homes registered, more than 6,000 older people living in these care homes. They have 18 suspected cases and almost 86 confirmed cases. From this, they have a few number of deaths, and this is the data from the biggest state of Brazil, in the state of São Paulo. They have more than 1,400 care homes, more than 30,000 residents. They have 875 workers that tested positive, and nearly to 400 deaths among residents, with outbreaks in at least 6 facilities, with at least 10 cases per care homes in 5 different cities in São Paulo states. We tried to get data from these public prosecutors and data from our survey. With this data, we have found a number of 7,000, more than 7,000 residents, and we are still finding a lower number of deaths among residents in Brazilian care homes. We have fewer than 100 deaths among more than 7,000 residents in this sample, but this is probably a biased sample because we are using a sample that have access to internet, a sample that is probably near to the places in Brazil that have more access to computer, more access to resources. So we know that in a country that is so uneven, probably places that have fewer resources, the mortality rates are probably bigger. So this is a research that has been recently published in PLOS ONE, is actually showing that the rate of mortality is bigger in places like the north region of Brazil, and a little bit lower in São Paulo state, for instance. Thank you.
Thank you very much, Patrick. Thank you. And now we're going to move on to Canada, and John Hirdes is going to be, I don't know if I pronounce your name well, but is going to be presenting on using inter-array data.
So thank you very much for having me. I'm delighted to be part of this discussion. My approach will be slightly different in that I'll talk about our experience of trying to deal with the COVID pandemic in Canada, where we have a data-rich environment for the long-term care setting, and some of the lessons we learned from the early phases of the pandemic. So what I'd like to do is to talk about the use of inter-eye assessment systems in Canada and a little bit about COVID-19 in the country, but then focus on how we use those data to respond to the pandemic, both in terms of the early stages of the pandemic and then what we're doing now, preparing for a second wave and potentially anything beyond that time period. And I'll give you some key points, summaries of what we learned in an environment where we actually are data rich, where we have a great deal of information about people in nursing homes, and some of the new challenges that we found that still created some barriers for us, even though we had a lot of data. So if you're not familiar with Inter-eye, Inter-eye is a not-for-profit network of over 100 researchers and clinicians in 35 different countries. We develop comprehensive assessment systems that can be used to identify strengths, needs, and preferences of vulnerable persons across multiple care settings. And we work together cross-nationally to create these instruments, to implement them, and to think about ways to use those data for different problems related to the healthcare system. These are the countries where we have members in the Inter-eye network, so we're pretty much around the globe. We started mainly in North America and Europe, but now are on all continents of the world in terms of where we have collaborators. And so for us, COVID-19 has been a huge issue because as a global network, much like the LTC COVID group, you hear what happens to your to the countries where your friends live, and you're concerned about that, but you also are concerned about what lessons you can learn from them to apply in your own country. So in Canada, we have implemented many of the different inter-eye instruments across the country. Each province it runs its own healthcare system independently. So we're a federated nation with effectively 13 different healthcare systems, but particularly our nursing home instruments and our instruments for home care. By home care, I mean care in the community, in private residence or apartment. Those two instruments are very widely adopted in the country. So as of December 2019, we had over 16 million inter-eye assessments on over 4 million unique individuals. And of that, about 6 million assessments were in the nursing home setting, about 7 million for community-based home care services, and we had 1.4 million assessments in inpatient psychiatry. There's many other sectors that are implementing our instruments, but those are the three biggest ones. So we had a lot of data potentially to work with. One of the things we like about the inter-eye instruments is they provide cross-sectoral comparability of measurement. So this is an example of our cognitive performance scale, which is validated against the mini-mental state and the MoCA as a measure of cognitive impairment, where higher scores suggest more severe cognitive impairment. And what you could do is these cross-sector comparisons to look at distributions of cognition. And you can see that in the nursing home settings, you have the most severe cognitive impairment. In home care, you still have a fair number of people that are severely cognitively impaired, but it's a somewhat less impaired population. Whereas in general inpatient psychiatry, cognitive impairment is less of an issue than psychiatric issues. But if you look at people who are admitted from inpatient to psychiatry in nursing homes, they have quite severe cognitive impairment, and people in nursing homes who came from psychiatry have the most severe cognitive impairment. So there's a great deal you can do with cross-sector comparisons with these person-level data. The typical uses for inter-eye assessments are for care planning, for person-level outcome measurement, for quality measurement, and also for funding and resource allocation. And all of these applications are fairly fully used in the provinces that have implemented these instruments already. Several are underway in their implementation, but I would say in my province, Ontario, you can see most of these applications used on a regular basis. So that brings us to COVID-19 when it came to Canada. And I would say that our country was caught flat-footed by COVID-19. We really started to see the start of the outbreak in mid-March. For context, I was at meetings in South Africa and in Belgium a month before, and most of the people that were in attendance were talking about COVID-19 in China. Once we were in South Africa, it had come into Italy, but Canadians weren't really talking very much about COVID-19 coming into Canada until really the first week of March. And in those early stages, as it became clear that our country was about to be hit, there were several problematic things that I saw in terms of the preparation for it. Chief among them was a virtually singular focus in the healthcare system and in public health services on the hospital system. There was fully a focus on keeping people out of hospital, not having the hospital system overwhelmed, and there was virtually no discussion about the risk to frail elderly adults. In fact, hospitals were discharging what they labeled ALC or bed blocker patients to nursing homes in order to make room for the future COVID-19 patients that were coming. And at that point, in the first week of March, the only evidence that had been published in the peer-reviewed literature was the reports from Chinese hospitals that really talked about age, underlying comorbidities as the major risk factors for mortality. And we'd heard anecdotal reports that there were bad outcomes happening in long-term care homes in Italy and Spain, but I don't think that really got the attention of public health people in the country. So what we tried to do in terms of the Inter-Eye Canada research group is to take the Inter-Eye data that we had and map those to the Chinese reports on mortality patterns. So in this table, what you see is population level data for Canada, the United States, and New Zealand, both in the nursing home and the home care settings. In Canada, we're also able to report on assisted living, which is like an unregulated nursing home, and post-acute hospitals, which are like a nursing home for very medically unstable clients. And we're able to compare those with folks in the United States and New Zealand. In all countries, the age distributions are pretty similar in the two settings. The gender distributions are pretty comparable, where the majority are female. And virtually everybody has an underlying comorbidity of something like heart failure, COPD, renal failure, liver disease, and so on. And in fact, if you look at people that have 3 or more of those, that's around 10% of the population, but only somewhere between 10 and 30%, depending on the sector, have none of those major underlying comorbidities. So with this table, we were able to sort of match the age and comorbidity distributions to the WHO report to make it clear that 60% of the nursing home population would be at the top of the WHO risk profile based on what they published around COVID mortality. And so then we tried to think about, well, how can we simulate the effects of COVID? Given that there were no COVID deaths in nursing homes in early March, we tried to think of a way to make the case to government to pay attention in this setting by doing some simulation around that. So what we decided to do was to use previous mortality data related to pneumonia as a proxy measure for what COVID might look like. Remember, at this time, we had no idea about the more complex nature of COVID affecting vascular systems. It was mainly being described as a pneumonia-related condition. And we had no idea what a COVID pneumonia looked like compared to previous pneumonias. But what we were able to do with this analysis, where we take into account age and underlying comorbidities, is to show that when pneumonia is present, it substantially increases mortality patterns in these two different settings, so that you, in the worst case, in the nursing home setting where people have 3 or more underlying comorbidities and were age 90 plus, you'd see a 30% mortality rate there for pneumonia compared to about 18% without pneumonia. And so we're trying to use this to make the case to public health and general government to say, look, we need to worry about the nursing home sector, and we need to mobilize resources that were there. At this point, when we'd released this evidence, the public health officer in our province made a statement that personal protective equipment was not needed in nursing homes. It needed to be preserved for the hospital settings. When we did the simulation models, trying to look at different scenarios of what might happen, we thought, well, you could model things, based on the percentage of cases that turn into a severe pneumonia, how many facilities would have outbreaks, what the infection rates would be of residents when an outbreak occurs. And under those, with those simulations in mind, our worst case scenario at the time was to predict about 1,000 deaths in Canada, 9,900 deaths in the United States, and 187 deaths in New Zealand. In actuality, we were quite wrong. Instead of 1,000 deaths in Canada, we had 6,000 deaths. Instead of 10,000 deaths in the United States, there were 50,000. And instead of 187 deaths in New Zealand, there were 10 deaths. So the scenario varied, much worse than expected in some jurisdictions, and much better than expected in other jurisdictions. But in fact, our call to try to get attention, say, look, this is going to be bad, was an understatement of what actually occurred. And so now in Canada, there's a lot of introspection going on to try to figure out, well, what happened that went wrong in the nursing home setting. In fact, 80% of our deaths in the country were in nursing homes. We had about 6,400 deaths, and 80% of those deaths happened in the nursing home sector that frankly was being ignored at the start of the pandemic. So what are we doing now? We're moving on to think about the analysis of the data for what happened, as well as trying to think about readiness for wave 2 should it occur. So one of the first things we're doing is we're looking at the quality of nursing homes, looking at using person level quality indicator data and linking that to the mortality patterns related to COVID-19 in those homes. But we're also going to be looking at what risk factors for individuals rather than nursing home performance, what risk factors for individuals like frailty, functional impairment, psychiatric diagnoses, medical diagnoses, how are they related to actual mortality data? We're about to get the coroner's data on COVID and non-COVID related deaths that we can link back to the person level assessment records. We can look to see what predicted whether somebody was infected or not. We have reason to believe that conditions like wandering or psychiatric symptoms might actually be associated with greater rates of infection within the home because of more movement around the home. We'll also look at what predicted hospitalization patterns, since we have linked hospitalization data as well. But we want to move beyond thinking about COVID-related illness or death itself to also look at what the consequences were of the lockdowns that happened in nursing homes, as well as the complete isolation in the community of home care clients. We're concerned that actually there's going to be an additional wave of illness related to neglected chronic disease management, because as COVID hit Canadian homes, there was virtually a singular focus on managing COVID risk, and we tended to ignore things like heart failure, COPD, and so on. So we expect that we're actually going to see an exacerbation of those conditions. We'll be able to use our clinical records to look at the mental health consequences, say for depression, ADL decline as a change in function, delirium and cognitive change, as well as increased severity of frailty, even if people didn't get COVID, or even if they were in a home that did not have an outbreak, we expect to see some of that. We're also looking at preparing for a second wave in the home care data. What we know is that the rate of influenza vaccination has been dropping in home care clients at about 25% not vaccinated. So we're trying to raise attention to that, so that we want to at least manage influenza in the fall, even if we can't fully control what happens with COVID. So to end with some of our key learnings from our experience with the first wave. The first thing is that even though we had a lot of data, there's sometimes a challenge in mobilizing those data rapidly. So in Canada, when an inter-eye assessment is done, it is sent in a batch basis on a quarterly time schedule to the national agency, Canadian Institute for Health Information. So every 3 months, those data get uploaded rather than real-time data. In Ontario, in the home care setting, I can get access to current data with about a month lag time, but we still don't really have real-time access to data. So now there's a discussion of taking all these inter-eye data holdings that we have in the country and turning them into real-time reporting systems to be more responsive to things like pandemics when they occur. The other thing that happened is what I call a tendency to turn off the lights at the wrong time. And by that, I mean that nursing homes actually stopped doing assessments in the middle of the pandemic, in part because staff were so busy taking temperatures multiple times a day, they didn't have time to do assessments. But as a result, they were not detecting things like deliriums or functional decline or exacerbation of chronic illness that might be happening in residents in the home. And there may be a time lag of getting those assessments back on track. And so we're pushing very hard now to get the homes that stopped doing assessments to resume so we can understand what the impact on residents has been. Another important problem that we had was problems with data linkages. And in fact, even today, we do not have an authoritative public health record for which homes had outbreaks and deaths. The Public Health Agency of Canada does not track that information. In fact, we had to get some of the information from media sources rather than from official government sources. And this has become a very clear issue that people see the need to fix, that public health needs to include the nursing home sector as an important population setting for dealing with public health issues. It should not be separated from the rest of the healthcare system. The other thing we're concerned about is there are many people who were, in quotes, decanted from care, where they had their home care services cut off in order to build capacity for people with COVID-19. And so we developed sorry for the typo, a COVID-19 vulnerability screener, a computer-based screening tool that could be used to detect frailty, COVID-19 symptoms, underlying comorbidities, and social vulnerabilities that might mean that people living in their homes in the community may be at greater risk even if they have mild COVID symptoms. And so we're now ramping up use of that in primary care settings and in home care settings where people have had services discontinued. So that's the end of my presentation. I'm happy to take questions and comments a little bit later. Thank you.
Thank you very much, John. So I'm going to go through the chat. We have quite a few questions, and I'm going to start. Let me see. Oh yes, going to Jenny. We have a question from Francis Dickinson, and the question is on involving residents and how to do that, and recognition that these may be challenging as the average length of stay in care homes. I don't know, as it says about 1.5 years. So don't know, Francis, if you'd like to rephrase the question, because I'm not sure I've read it very well, but you can pose it directly to Jenny.
Yes, so I just thought it's in principle, obviously, you would want to involve care residents in those discussions, but I just thought in a practical sense it might be quite difficult, partly because although a few stay for some time, the average length of stay is quite short. And also there's the issue of, the capacity to engage as well. So I'd be interested what Jenny thinks about those points.
So thanks for that. I mean, I think some of this is about, I guess, looking at the data that we are collecting at the moment, a lot of which are obviously very health outcome focused, and seeing whether there are other measures that are important to residents about their care that actually should be being more systematically recorded. Also, I think there is a bit of dialogue that needs to take place about the data that are collected in order to look after someone in a care home, but the data which might be of interest to researchers, practitioners, policymakers, and whether those things do directly overlap, or whether there are some domains of care that actually are really important to deliver frontline care, but not necessarily the sort of things that people want to see in academic papers. and looking at that at an individual level where perhaps those variables can then be linked into other bits of their health journey. I agree that it's challenging, and I'm very fortunate that in the DACHA study we have a really great team who have lots of experience involving residents, and I think it's probably something that's been underdone in terms of establishing relationships within homes and talking to residents about what's important and what they think is acceptable. Clearly there are issues around the high rates of residents who lack capacity, but I think the general principle also that we can always ask people what matters to them and what's important, and that probably actually in healthcare we take a bit of a paternalistic view at times and tend to overlook those views a little bit too often. It'd be good to hear what residents think is acceptable and how they feel about things. So yes, it is a tad aspirational in terms of thinking everyone can be involved, but I think something that needs to turn our focus of attention so that social care data are used to better the care of residents from their perspective as well.
Thank you very much, Jenny. Going to ask now Jose Luis. We've got 2 or 3 questions, quite specific, some of them. So there's one from Richard Humphreys asking if you could say a bit more about the size of care homes. Is there a number of places at which the risk is increased significantly?
So we created the 3 groups that we did just simply in order to have the same numbers of care homes in each. The regulator in England uses a slightly different definition, which we've also used in order to look at patterns but you see very similar effects. And in fact, in the modeling, when we've used the models, we haven't used categorical, so we haven't grouped homes. We've used the continuous indicator of the size, so numbers of beds, and that works perfectly well. So I wouldn't say that there are some very specific thresholds where things change, or at least we haven't picked that up in our analysis.
Thank you. Then the next question is about the quality of care and deprivation areas from Michal. Hi, Michal. So can you say a bit more about that?
Okay, quality of care. So what we
found.
Presumably that relates to the slide where I was saying that there are some correlations between COVID outcomes by so prevalence of COVID and also mortality and quality. Now, this is one of the challenges of trying to pick out those sorts of effects is that although we've got a lot of data because it's a panel, so we've got daily data for lots of homes for what are now 3 months. Those sorts of indicators are time invariant, and so you don't get a lot of variability, and you don't get, it's before COVID started whether you were rated good or so the regulator uses a 4-level sort of a variable, but there are very few cases in the extremes, and so what we did was to group homes in terms of whether they were good or outstanding or anything else, and that you do find it's not the most significant of effects, but then you wouldn't expect it to be because of its time invariant, and therefore there's not a lot of variability to look at. But you do find that homes that were rated as good or outstanding before by CQC seem to be doing better with regards to some of the outcomes. And then deprivation is the same. There's quite a few deprivation indicators. Again, we're looking at deprivation before COVID, and therefore there's a limitation in terms of the variability in the data. And it's particularly deprivation related to health, so health deprivation in the community that seems to be, so higher deprivation, worse outcomes. We're doing further work in those in order to really be sure that what we're finding is reliable, but that's what we're finding at the moment.
Thank you very much. And there's one more question for you. So now, as we are on to continue, which is about, so it's from Maria Aurora Senex, says, I thought you said that initially staff could not attend to care homes. If this is so, why was the reason for staff not being able to attend?
So the data we get just asks whether staff are unavailable because they need to self-isolate, either because they themselves are ill or looking after somebody. that is ill. So we don't know exactly the cause, but that was the way the question was phrased. What is important though is that as you see that big peak of, up to, very quickly 4,000 staff not available. So these are staff that would have usually been in those homes providing care. What is also quite noticeable is that the impact in terms of the ratio of workers to residents did not move anything like that. And the reason is that homes were able to, I guess it's easier if you're in London, because it's the population density, and they were able to tap into agency staff quite quickly, and so the impact in terms of the ratio of staff to residents didn't change that much. But of course, if you're using agency staff, that in itself is a challenge because of the risks of COVID coming in with them, and they're more likely to be working across care homes, etc.
Thank you very much. I'm now going to see if any of the other speakers would like to come from the experiences of your countries, your data in relation to these questions. Particularly, I'm going to move a bit towards the quality, and I'm going to also use this to make a plug for one of our, so the 6th of July, we'll be talking about opening care homes to residents, but on the 13th of July, we're thinking about a webinar to bring together the people who've been looking at the sector of ownership and COVID, which is an area in which there's been quite a lot in the press, quite a bit of speculation and some initial look at data. And I think that will also be picking up some of these quality issues. So I don't know if Patrick, you talked a little bit about in Brazil about is it unregistered homes? And I was wondering whether you had any initial indicator of, for example, whether these type of homes were at particular risk.
Yes, we have a lot of difficulty to find these unregistered and informal care homes, because they usually work, but as in Brazil, most of the care homes they are not recognized as health care units, but as social care units. So most of the data produced or used, for example, to inform COVID-19 actions, they are not related to healthcare sectors. So that's why we had so much difficulties finding data. And when we tried to find data that is not related to notification of suspected cases, during our research, we identified that the public prosecutors were in touch with these care home sectors probably more than 10 or 12 months prior to the pandemic. And particularly with these unregistered care homes, because they are trying to get in touch with them to find if there were violations to human rights, and how they can help them. And as we usually can't get in touch with these care homes, getting in touch with public prosecutors were the only way we can find these care homes. So it was very helpful, because the health care system usually don't have the touch with these unregistered units. So it was very interesting. We have 26 states in Brazil. Probably in 10 or 12 of these, the public prosecutors are doing this kind of work, getting in touch with care homes that are not registered. It is not all of them.
That I'd like to add that I've been hearing some anecdotal information from Spain, where they've uncovered quite a few care homes that they were not known to be existing due just because they had large number of deaths. Quite often they were religious institutions that had de facto become care homes, again fulfilling a more social need perhaps to start with, but then the residents were aging and becoming more and more frail, and then through having lots of COVID deaths, they were suddenly detected by the system. So it's also something that is an issue in Europe. And we heard a little bit about unregistered care homes in Malaysia in a previous webinar as well. So I'm now going to move to John. John, here, because we have a few questions for you. We have one from Catherine Henderson asking which provinces have the lowest, highest proportion of deaths in nursing homes, and how about retirement homes?
Yeah, so it's important to differentiate those two types of settings. And I would also say for this network in general that you'll find a great challenge in trying to come up with a common facility level definition for what we would call a care home, nursing home, long-term care home. It's almost impossible to do internationally without person level data. In Canada, when I did my first chapter on care of the elderly in nursing homes in the country, I found over 40 different names for what we would otherwise call a nursing home within Canada. So when I talk about nursing homes and the data that I was showing you, those are regulated facilities providing 24-hour care with nursing staff on place, and they tend to have high levels of cognitive and ADL impairment, but not necessarily a lot of medical instability. Retirement homes or assisted living might in some countries be called residential care, even though in Canada, residential care facilities in one province are nursing homes. So retirement homes are unregulated. They tend to have a less impaired population overall, and they're private pay fully. But they are increasingly becoming like nursing homes were in Canada in the 1980s. So when we report in our country that 80% of deaths happen in long-term care, it's actually in both of those types of homes. So we actually don't know what the right number is for deaths in nursing homes alone because public health does not report that yet. I am about to get the data so I can break that out separately. So in terms of the country, the provinces in the country, the ones that were worst hit were Quebec and then Ontario and then British Columbia, where most of the deaths happened. In some provinces like New Brunswick, until last week, they had no deaths. They've had one death now because COVID came into the province in the last 2 weeks. So by far the biggest determinant of nursing home deaths in the country is community spread. If there's not an outbreak in your community, you're not going to get nursing home deaths for the most part. So really you need to focus on jurisdictions where there is community-based spread. The issue of looking at quality becomes very tricky. So we're doing a very careful analysis to look at quality indicators at the nursing home level, look at specific indicators, so predictors of related to infection control, ADL impairment, cognitive impairment, all those clinically specific indicators to see how they relate to COVID-related deaths. I don't think you only want to rely on 5-star indicators. I think it's more informative to get more specific with that. We now have the data to be able to do those analyses, and we're working on it right now. But what I would say as an issue for us to think about for doing international comparisons is you really can't talk about quality comparatively if you haven't done proper risk adjustment. So if you have an indicator that's unadjusted, you have a very high probability that you have better outcomes in the homes that serve the lighter care residents. And without that adjustment, you cannot make inferences about quality. With our analysis, we'll be able to do multi-level analysis. So we'll be able to look at the quality ratings of the home, which are reported nationally on a daily basis. You can look up nursing homes in Canada right now through the Canadian Health Information. We'll look at those home level quality indicators, and then we'll look at the person level in a multi-level model to see if you're a frail person in a poor quality home, did you have a higher probability of dying than if you're a frail person in a good quality home. When it comes to facility level characteristics, nobody has yet reported what Jose Luis reported in terms of the size of the facility, although I would buy that that's probably a pretty good risk factor. What has been reported is that when it comes to the difference between for-profit versus not-for-profit homes, most of that variance that we've seen is explained by differences in the age and architectural design in the homes. So in Ontario, the for-profit agencies tend to have more homes that are older and less well designed. So they have more rooms that are 4-person bedrooms, and that's where COVID deaths were more pervasive. So it becomes a very complex issue to disentangle. People like to rush to judgment to make one specific inference about what truth is. But in fact, you need to have fairly robust data and do fairly careful analysis to tease out what really happened here. And so we're in a good position after the fact to disentangle what happened in Canada. You know, my focus of my talk for you guys was to show you the struggle of when a tsunami is coming your way, trying to prevent some deaths, and it turned out to be quite difficult. But that's why our focus now is on trying to be ready for a second wave and trying to best understand what actually happened.
I follow up asking a bit about Canada. So in the UK, we've complained a lot that because we didn't have very good data, then of course we couldn't have had that data in the models. And therefore we couldn't, you know, with the epidemiological models that were being used to inform the initial stages of the pandemic couldn't have included care home residents, listed individual level data for them. But of course in Canada you did have the data. So you had the added frustration of having the data at your fingertips and having done the analysis. Would you care to comment a bit about what you think were the barriers for this type of analysis and work you had done to be taken up in terms of the pandemic planning?
Well, for the planning, you know, we were actually able to make a case based on what we knew from WHO that this is a very severe high-risk population that we're dealing with in the nursing home setting and in community-based care. So in home care services, so people living in their homes and receiving home care services, 40% of them were at the top of the risk profile that WHO published in March, 60% in nursing homes. So we got that case out. We were able to get that information out to provincial government agencies by the third week of March. But the focus on hospitals was absolutely singular. Nobody wanted to hear anything about any other setting. They were exporting people from hospitals into nursing homes. They were cutting people off of home care services to build more capacity for the hospital system. And so when the pandemic was at its peak, what you heard in hospitals was crickets. There were a lot of empty emergency departments where people were not coming in, but the disaster was hitting nursing homes where they were denied access to PPE. There was no screening happening of staff in those settings. So we had the data, but the political focus was on the wrong spot. And I think now that's going to change now that we've seen what the impact has been. We had one provincial premier whose mother-in-law was in a nursing home affected by COVID. So I think it got his attention as well as his government. And, you know, honestly, before that, they were responding to it. But I think we're now in a position to better use these data. And that's why there's a review happening in the country to say, aside from having the data, what are the other things we needed to have happen more rapidly? And the gap between what the public health agency was reporting and what healthcare information providers were reporting was a major problem where we, you know, today you still cannot get a definitive list in the country of all the nursing homes that have had outbreaks because public health has not reported that.
Thank you very much. We've got a question about the symptoms of COVID in care homes. And I was wondering, Jenny, whether you'd like to comment to that. So the question is, when you consider symptoms of COVID in care homes, does that include typical symptoms, cough, temperature, or also atypical symptoms in all the people, delirium, falls, diarrhea?
So obviously from a data point of view, that part of the story is very much missing. From a clinical perspective, very much the atypical presentations have been quite predominant, and I think it'll be interesting to look at the changes in detection over time in relation to testing policies, as testing certainly in Scotland became more accessible as time has gone on, and also more recognised the value of whole care home testing as opposed to identifying residents with typical symptoms. But I think it's something that's becoming increasingly well described and echoes that of the inpatient hospital geriatric population, where again the atypical presentations have been predominant.
Thank you very much, Jenny. We've got another question for John. Well, one was about these very disturbing examples where the military had to take over some care homes, and we've also, of course, heard some of that happening in Spain. Don't know if you want to talk a bit about whether that surfaced in your analysis, but then there's also a related question, or not related, sorry, but another question for you, which is whether you've looked at cases of deaths for those getting home care.
Yeah, so there's been a handful of very high profile, horrible situations of homes where there were huge numbers of staff who got sick, as we've seen by other presenters, and then other homes where staff quit working or walked out, and that was in a very small number of homes. Those are certainly going to be subject to coroner's inquest or reviews to find out what happened. The cases where the military went in, it was really driven by lack of staffing to be able to care for the people that were there. And you know, then the military released a report on what they saw in those homes, and there were some clear cases of what really felt like neglect happening. But some of the things that were in the military report were also a reflection of what homes were being told to do. So there was a report that staff were reusing their PPE over the course of the day. In fact, when I've spoken to long-term care homes, they were ordered by public health services to only use one mask per staff person per day. So what the military was reporting as a quality problem was a directive, in fact, from public health services to those homes. When I've looked at the homes that had some of the worst outbreaks in terms of their pre-existing quality indicator profiles, I would say they looked mediocre, but not horrible. They did not stand out as the worst imaginable possible homes that, based on our data, but they certainly didn't look like exemplary homes either. And right now, you know, since I haven't analyzed the data, they're literally just have just arrived. I think what we'll see is an ambiguous picture. There won't be a clear relationship between good quality, meaning good outcomes, in that relationship. And you know, I'm happy to report back to this group once we've done those analyses. The other question was around the home care setting. We are looking at the home care data as well. There'll be a bit more of a time lag to get the coroner's data on mortality in home care. But if I do the math, we had around 8,200 deaths in the country, and about 6,400 of those deaths are in nursing homes or retirement homes. The bulk of them, the highest number was in Quebec. That leaves around 1,800 deaths that would have happened in non-care home settings. If I think about the size of the home care population, that means that we saw less mortality in home care. My guess is that there will be some folks who had worse mortality and had higher hospitalization rates, but you know, we'll have to see that when we get the data. I think the bigger implication for home care is going to be the impact of social isolation on depression and functional decline in those settings. And I think we really need to think of COVID as having two major health impacts. One of the illness itself, and then the secondary consequences of all the measures that we put in place to counteract the illness, the unexpected negative consequences of isolating people, keeping them very strictly constrained geographically and in their rooms in long-term care homes. So there's really two parts to tease out, I think.
Thank you. I'm going to use a little bit of time and let Mikhail, who's just raised her hand, have a very quick last question. Yeah, Mikhail.
Hi, it's been a fascinating conversation. It was just an overall understanding. When a case has been identified a care home. I'm kind of curious to hear what happens next. I'm based in Israel at the moment, and we have a very clear, we pulled the person out, we created units for people who are COVID positive, symptomatic or non-symptomatic in a different place. We sent in the troops to disinfectant, and we start sampling the care home residents and all of the staff kind of in regular intervals. So there's a real big push at the moment, and I was just wondering what happens in other places when that first case is identified, if it's similar, if it's different. Yeah, just wondering about that, the next step. Thank you.
I think I'm going to actually abuse my position and answer that one and say that we've seen, because we're running out of time as well,
Okay.
we've seen a very distinct approach to this. So in many Asian countries, so we had the webinar and we have the video available. So we heard from Malaysia, we heard from Hong Kong and South Korea, and in particularly there the approach has been much more to remove the person and not to even attempt to isolate within the care homes. I think in most European countries, although we've seen some examples of people being removed in Spain, in most European countries the approach, and also in Germany, sorry, but most of the other countries, they've attempted to isolate in the care homes. And I think it's similar, if I'm correct, in the US and Canada. We haven't seen so much of this removing the 1 or 2 infected cases very quickly to then, right. And there's a lot of discussion about this, whether this is also cruel on the people that you're removing and so on, because so many of them have dementia. I think it's one of the things that we'll need to be looking at whether these different approaches have made a difference. I think here is where more research data, more studies will be helpful. Patrick says that in Brazil, care homes in some states must inform public prosecutors about confirmed cases. Thank you, Patrick. I'm now going to close for today. Just a quick plug. We're not going to have a webinar next week, but the week after, we will be talking about reopening care homes. And we'll be hearing, at the moment, we've got speakers from the UK, from the Netherlands and Australia. We're going to hear about the experiences of reopening to visitors and family. If we have room for one more speaker, so if anybody's got some interesting examples from their country, please let me know. And on the 13th of July, we'll be discussing the role of home ownership. And again, we have still room. We have 2 speakers. We have room for 1 or 2 more. So if you'd like to join, please send me an email, a message. You can find me, if not through LBC COVID or Twitter. And thank you so much for all your questions, your presentations. This will be online. As ever, happy to continue the conversation. If you've got anything you'd like to share, LBC COVID is always happy. Even if you've published somewhere else, you can just do a blog post announcing your work. So thank you very much. Wishing you a good 2 weeks, and see you all very soon. Thank you. Bye.